So now it's our pleasure to introduce our plenary presenter, Dr. Terri Aldred. Is she on the screen? Perfect.
Over to me.
Doc, we're just going to introduce you to the audience, Dr. Terri Aldred. Dr. Aldred is a Kel carrier from the Tlasdin territory, located north of Fort St. James. She's a Lisilo frog clan who are traditionally known as the boys of the people. She follows her mother's and great-grandmother's lines, Cecilia Pierre Prince. Dr. Aldred grew up in both the inner city of Prince George and on the Taché Reserve in Lake Babine territory. And these experiences helped to motivate her to go to medical school so she's able to contribute back to her communities. Dr. Aldred has a Bachelor of Health Sciences degree and a Doctor of Medicine degree from the University of Alberta. She then went on to complete the UBC Indigenous Family Medicine Residence Program. Currently, Dr. Aldred is the co-site director for the UBC Indigenous Family Medicine Program. She's also family physician for the Career Sekani Family Services primary care team that serves 12 communities in North Central BC, the executive medical director for primary care for First Nation Health Authorities, Indigenous lead for the RC-CBC, and editorial member for the BCMJ. She was a recipient of the 2018 BCC FP's 5 Years in Practice Achievement Award, the 2020 RDOC Mikhail Award for Medical Education, and the 2021 Alumni Horizon Award. She's passionate about Indigenous health, physician well-being, and medical leadership.
Culturally unsafe care and anti-Indigenous bias have negatively impacted the health of the Indigenous people across Turtle Island since settlers have arrived and established healthcare services. A number of reports, including the Truth and Reconciliation Report and First People's Second-Class Treatment Paper, have clearly outlined the health impacts and have clear recommendations on how to address health disparities seen in Indigenous people in Canada. More recently, and closer to home, the BC In Plain Sight Report, HSO, BC Cultural Safety and Humility Standard, and the CPSBC Practice Standards have been published that share BC stories and data and offer additional recommendations and standards to be implemented in the healthcare system. This work has raised the awareness that culturally unsafe care and racism are serious determinants of illness for Indigenous people in BC, and there are a number of important steps we can begin to take now. We will walk through the history and foundational documents to highlight the consistent themes, recommendations, and calls to action to inspire a discussion on what the work looks like at the bedside, in our departments, and with our team. So without further ado, I'd like to introduce Dr. Terri Aldred.
Hello. Thank you for the warm welcome. I'm happy to be Zooming in today. Apologies, I can't be there in person. I am currently on the Notley-Wet'suwet'en traditional territory, which is just by Fort Fraser, where I have one of my outreach clinics today or this morning. And so early drive out from Prince George. Yeah, and so again, apologies I can't be with you all in person, but appreciate being able to Zoom in to talk about this important topic. And so as mentioned, I am Decaf from Tlasdin, which is located just north of Fort St. James. I was born in Prince George and grew up pretty much all over North Central BC. I'm a family doc by profession and have a few roles, one of which is as the Executive Medical Director for Primary Care for FNHA. I'm also still a faculty member with the UBC Faculty of Medicine supporting the Indigenous Family Practice Site. And I have a role with the Rural Coordination Center with their Indigenous health initiatives, and as a family physician with Carson County Family Services, which brings me out to Notley. I normally live in the Lheidli Traditional Territory, otherwise known as Prince George. I've been working with cultural safety and humility practices pretty much since the day I walked into medical school. And today's talk is looking at cultural safety and humility and anti-Indigenous racism, particularly post the foundational reports and recommendations that have come out in the last few years, as well as distilling some of the key tenets around how we can incorporate those standards and recommendations into particularly the clinical part of healthcare. And so I already jumped the gun and did my land acknowledgement. I'm an uninvited guest on these traditional and stolen territories, and I have relatives across north central BC, across the Carrier Nations, including in Notley and Lheidli, with many aunties, uncles, and cousins. And as mentioned in my introduction, I also spent a lot of time in Lake Babine traditional territory growing up. And I would encourage you all, if you do not know the traditional territories that you currently live, work, and play, native-land.ca is a great resource. Or if you would like to look up maybe where you grew up, to acknowledge the ancestral lands that we currently inhabit. And doing land acknowledgements is a truth and reconciliation call to action, and it recognizes that that there were people here that inhabited the land before settlers arrived, in an attempt to address the fact that a lot of history from an Indigenous lens or perspective has not been shared. And so this morning I'm going to review some key terms and important milestones to hopefully kind of land us in the space. And then I'll review very quickly some of the key findings around clinical practice in the In Plain Sight report and recommendations, as well as do a high-level review on the Cultural Safety and Humility Standard, which is currently being put through the process to become an accreditation document that will apply to health authorities as well as other health service organizations, as well as the College of Physicians and Surgeons of BC clinical practice guideline. It's also important to note that within the last little bit, I think few months even, the College of Nursing and Midwives has also released their standard, and I believe many other colleges are going through this important process as well. And then I'll finish off with highlighting some of the key recommendations for clinics and clinicians. I'm happy to take questions throughout if there's a good way to notify me. Otherwise, we should have lots of time at the end for some questions and dialogue as well. And so some of these important milestones include the signing of UNDRIP, otherwise known as DRIPA in BC, into law, which made history in Canada and in many jurisdictions. Brian Sinclair, and so an UNDRIP, the United Nations Declaration on the Rights of Indigenous People, highlight a number of important elements, including Indigenous people's right to our culture, language, lands, as well as to programs and services that will help us achieve our highest level of well-being, including access to our own traditional medicines and practices. And some other important milestones include the death of Brian Sinclair in 2008, which is one of the impetus for developing the paper First People, Second Class Treatment, which was published in 2015, which highlighted that systemic racism has been embedded into the Canadian healthcare system since its inception, And it's a lengthy read, but it goes through in great detail exactly all of the different ways that systemic as well as interpersonal racism and discrimination has impacted and continue to impact the health and well-being of Indigenous people in Canada. The Truth and Reconciliation Report was published in 2015. That coalition traveled across Canada and listened to over 6,000 survivors of residential and day schools, and recorded and documented their experience both in writing as well with testimonials, as well as through video and other means. And from those findings, 94 calls to action were written, including 8 specifically designated for the healthcare system, although there's many in other domains that also cross over and pertain to healthcare. And then we have the In Plain Sight that was published in 2020. And the impetus for that was reports that there was a racist game being played in emergency rooms across the province. And this report was intended to look into Indigenous people's experiencing access and care. Joyce Esquan died in 2020. There has now been Joyce's Principle that has been drafted, and many places out east in Quebec and Ontario have approved or signed Joyce's Principle, which essentially says that Indigenous people have the right to access services free of discrimination and racism. HSOBC Cultural Safety Standard published in 2022, and that it was a standard I supported as part of the advisory group, and so this framework went through on what are the standards around cultural safety that we want to embed into the healthcare system at all levels. And then, as I mentioned, the CPSBC Cultural Safety and Humility Practice Standard was published again in 2022, and that was in partnership with the FNHA. And so I often refer to many of these terms, and so I think it's always important to ensure that when we speak to these terms that we have a shared understanding, or at least you have an understanding of what I'm referring to when I speak to these terms. And so colonialism is the policy or practice requiring full or partial political control over another nation, occupying those settlers and exploiting it economically. Neocolonialism is the use of economic, political, and cultural or other pressures to control or influence other nations. And I think when we look at that definition, it's hard to argue that colonialism and neocolonialism doesn't continue to impact Indigenous people in Canada. Cultural humility and awareness. So this is an active process of regular self-reflection on the practitioner's worldview and life experiences and how that may impact the work that we provide with our patients, and to acknowledge that our worldview and biases may not necessarily reflect the people that we're serving. And this is the part of the journey that we as practitioners have control over, is to develop cultural awareness and ongoing reflection and a practice of cultural humility. Cultural safety can only be defined by the person receiving care. So it's really the goal of developing cultural awareness and humility. And so we as practitioners cannot define whether or not we are culturally safe or the care that we provide is culturally safe. We need to acquire that information from the people we are serving. And so it comes to the point that, you know, as practitioners in healthcare, I think we all have good intentions to provide the best possible care. And we also need to have ways to assess our impact of that care on the population we serve. And it's, I'm sure, an area that this conference in particular focuses on when we look at QA, QI, and how do we improve the healthcare services that we're delivering and assess that. But on a wide scale is not something that we regularly do. And so I'm going to jump in. I'm actually going to share some work that came up through the RCCBC Rural Site Visit project around cultural safety and anti-Indigenous racism. This project was not intended to assess or look at these things initially, but it came up in discussions with health system partners around healthcare service and delivery. And currently we are drafting, or we have a formal paper written. And so these are just small excerpts from that to highlight some further definitions on what we're speaking to, and wanted to use these examples because these are examples that came from BC, particularly rural and remote areas. And so systemic racism is found in societies where one dominant social group has disproportionate access to power and resources, leading to avoidable, unfair, and inequitable laws and regulations between racial groups. And it manifests as social exclusion and isolation. And so the quote was from an Indigenous community meeting and member, and they expressed, "What keeps me up at night? It's the racism people suffer. I mean, the residential school for the region was right here. And so that is on the surface still, and a very real experience for people that I still think we're not doing a great job of caring for. There's just so much trauma that falls from that. And then, yeah, people suffer here. And when they wouldn't suffer if they had easier access to healthcare. And a lot of people tell me, I'd rather stick it out and suffer, you know, die uncomfortably." Epistemic racism is a form of racism where we use one set of knowledge systems to validate another set of knowledge systems. So for example, in Indigenous health work, it could be using like a Western-based evaluation system or metrics to assess Indigenous people's ways of knowing and being, and whether or not there's quote unquote benefit for Indigenous people in healthcare settings. And so it's something that it's a form of racism that can be very insidious, that could be done with the best of intentions, but again, has this implicit nature that one set of knowledge system is asking in another people's or another set of knowledge system to validate itself against their worldview and their metrics. And this quote came from a health administrator meeting. So our settler population don't really appreciate the history because they've only been given it in one form. So we have been taught history in a certain way that is the perspective of the people who wrote the books, who are also settlers. We don't get a lot of, you know, Indigenous historical material to reflect on to get the other perspective of the same events. And so, you know, you've got a lot of potential for education here, for sure. And it's important to know, especially in our present day, that a lot of Indigenous ways of knowing and being and knowledge systems are actually being lifted and raised up as being, you know, gold standards, if you will, on things like how to treat and manage trauma, how to cultivate things like resilience. And one of the easiest examples that I can use is the Maslow's system of hierarchy. In that, and so Maslow actually spent a lot of time with Southern Blackfoot nations in the prairies, and that's and from that experience is how he developed that Maslow triangle. However, his interpretation was a bit off in that he put self-actualization at the top, when actually for many Indigenous peoples, that is actually at the bottom. So it was understood that a fundamental element of health and well-being is being rooted in knowing who you are who your kin are, your place in that community and nation, and really understanding your roots, and so that you could be strong and firm in your in who you are, and really that work is vitally important, which points to the fact that a lot of our traditional knowledge systems were around being rooted and connected to the land, ways to look after our energy, and to cultivate our spirituality and our sense of oneness and connection with all living things. Interpersonal racism is the most obvious and is the one that we think of the most often. And it occurs when individuals experience some form of discrimination on a personal level. And these acts of racism occur between people in range and severity. And so if you look up the scale of racism, I didn't include it in this PowerPoint, but it's easily Googleable. Essentially it shows that interpersonal racism can exist on a spectrum. And so on one end, you have like, white supremacy and acts of violence and that sort of thing. And on the other end, you actually have allyship and accomplice. And usually somewhere in the middle is white saviorism and various forms of denialism, which is, in my experience, very rapid in the healthcare system, because again, we come at it with wanting to help. And sometimes that can take the form of saviorism or needing to rescue, or less listening and more I have the answers, or saying like, you know what, I treat everybody the same. I just see like, bones and muscles, like I don't see skin color. So, I mean, racism doesn't impact me or my work. And so along that spectrum, the reason why allies and accomplices are still on that spectrum of racism is because if there's a society where a group of people need to have allies and accomplices, that by definition means that society is not safe for those individuals. And so that's why I say it's a spectrum, and we are all on that spectrum. A client, and so these quotes come from an Indigenous community meeting. So a client came struggling with addiction. Sorry, I need to move my box here. And his past historical trauma was never put into any consideration at all. He told me, I went to the hospital and they told me that I was fine. The doctor didn't even listen to my chest. So I, a First Nations health director, went with them back to the hospital, and the difference he received in service was unbelievable. It has always been hard to go to the hospital as an Indigenous person. Ever since I've gone to the hospital, we have been discriminated against. And so in many other quotes also from non-Indigenous folks who may be in emergency rooms or healthcare settings in various ways, also spoke to the fact that it was really hard to necessarily name specific comments or behaviors, but there was a general sense, and that it was obvious to them. Even some of our like lay people, from, for example, the mayor and council members would say things like, when I was there, there was a sense that you could tell that there was a change in behavior or a change in approach when they were talking to Indigenous versus non-Indigenous people. And it speaks to the subconscious nature of these implicit biases that we may not even be aware of, subtle things in body language, how we're communicating, and even others have a hard time pulling out the specifics of it, but it is felt, and it's also felt by the patients. So with those with those examples fresh in mind, the In Plain Sight report was obviously a much wider scale across BC report that listened to over 9,000 individual voices collected through surveys, submissions, and interviews that found that systemic and widespread evidence of anti-Indigenous racism existed in BC's healthcare system. The negative stereotypes, biases, and discrimination results in significant harms, including death, that Indigenous women and LGBTQIA2S+ were particularly impacted by this discrimination, which highlights the intersectionality in the layering of how racism impacts those who identify in multiple oppressed and underserved groups. And this creates a cycle where Indigenous people experience racism when accessing care, and then start to avoid or delay accessing services, which result in poorer outcomes. And these biases that were discussed include that Indigenous people are less worthy of care, and this is supported by anti-Indigenous racism research that came out of the States and New Zealand. The idea that Indigenous people symptoms are often minimized compared to non-Indigenous folks, that Indigenous people are drinkers and drug seekers, that they're bad parents and frequent flyers, that they're irresponsible and non-compliant, that they're less capable of the non-Indigenous people and are unfairly advantaged. And further, that came out again. This report was published in the fall of 2020, which was right in the height of the COVID-19 pandemic, and it was already evident that Indigenous people were being disproportionately impacted by the COVID-19 pandemic, as well as the toxic drug crisis. Indigenous healthcare workers face significant racism and discrimination, and so there was a dedicated stream looking at reports from people working in healthcare, both Indigenous and non-Indigenous folks. And so the Indigenous healthcare workers did highlight that they do face a lot of racism and discrimination in their work environments. That current education and training that is available is insufficient, that feedback and complaints processes are inadequate and do not work for Indigenous people. Indigenous values and practices are not incorporated into the current healthcare system. So again, famous quote that I'm linking right now on the author, but that says, like, there is a difference between all are welcome here, and this was created with you in mind. Indigenous people need to be integrated into the healthcare system at all levels. And so again, this was particularly highlighted by other Indigenous healthcare workers that said that they felt like the main way to address the discrimination they face in their work is actually to have increased representation, which is highlighted in the Truth and Reconciliation calls to action, as well as the First People, Second Cost treatment. No accountability framework, including lack of system-wide data collection and monitoring process. Hey, good one for this group. And that's in particular related to the fact that because we don't have a good process of collecting feedback from patients in real time and efficient ways to respond to that data, that a lot of the inequities of oppressed and underserved people can actually be disguised and not raised to the forefront, and therefore have inadequate resources and step-by-step processes to actually improve those outcomes. In Place Site Task Force established a number of working groups, and the task force is now wrapped up. They had a 2-year mandate, and so the work of those working groups has transitioned into other systems and structures to continue, with the understanding that it took hundreds of years, and even before settlers arrived, so really thousands of years of systemic racism, and we weren't going to necessarily be able to solve it in 2. Regional health authorities and regulatory bodies in BC have all reviewed and adapted their complaints process, including many that supported Indigenous people to come into roles to help kind of support Indigenous people when they're choosing to file a complaint or offer feedback in other ways. Indigenous leadership has been enhanced with a number of key roles established in regional health authorities, including increasing Indigenous health portfolios with VPs of Indigenous health, as well as Indigenous medical directors, etc. Employment agreements, the PMA and medical staff guidelines are reviewing and incorporating cultural safety and anti-Indigenous racism guidelines and deliverables as well. Reference to the practice standard, which we'll get to. So the HSO and FNHA developed this practice standard over a few years. It started pre-COVID and was ultimately published in 2022. It did go through quite a lengthy review process as well as multiple rounds of engagement. And so just to share this one quote about the standard. So the standard will be designed to apply to all types of health and social service organizations throughout the province's health system. It will address the structural, systemic, and provider levels, as it is acknowledged that change is needed at all three interconnected levels for real transformation to occur. This document is intended to apply to the province of BC and to be used as the benchmark on organizational progress. This document is intended to address organizational structures and processes and not intended to be used as national standards, clinical practice, or cultural specific contents. So again, it's looking at system processes and procedures around systems level change. There are 8 domains of the practice standard. Sorry, I'm just catching up to my notes. And so, one, supports social, public, and reciprocal accountability. And so this was a big call for leadership to demonstrate a commitment and utilize Indigenous-based reports, guidelines to inform their work. And that there is an accountability framework with zero tolerance policies and establishment of a speak up culture, where at this point there is no real accountability structure around cultural safety and humility and anti-Indigenous racism. Number 2, establish inclusive and meaningful partnerships. And so the recommendation was that an organizational lead is established to lead the work in building collaborative relationships with First Nations, Métis, and Indigenous peoples, which comes back to the promotion and expansion of Indigenous health programs and regional health authorities, to develop collaborative agreements that outline roles, responsibilities, and reciprocal accountabilities. Organizations partner and co-design programs and services to meet the needs of Indigenous people, and that adequate resources are allocated. And that there's a culture of truth-telling to ensure that there's effective engagement in community, recognizing that truth comes before reconciliation. And so we need to create those relationships so that we can have those safe but fierce conversations about where we currently are and a clear path to where we want to be. Number 3, share governance and implement responsible leadership. So structures and nation-based governance to eradicate anti-Indigenous racism, including holding, governing, and leadership positions within the organization, developing operational plans to address anti-Indigenous racism, and implement senior leadership who is responsible to oversee this portfolio. And again, founded in the principles that nothing for us without us, that leadership works in lockstep with First Nation, Métis, and Inuit people to ensure that it works and serves their needs. Invest in financial and physical infrastructure to ensure that there's a welcoming environment for Indigenous people whenever they access care. Adequate resources to help address goals and wellness priorities. That programs and services are sustainable over time. Physical spaces are co-designed. Spaces support the values of Indigenous people. Spaces support the values, and support them to gather in these spaces. And so, so essentially that spaces are co-designed and that they are available and encouraged for use for Indigenous people, of course. 5, develop human capacity. So it's important to develop HR processes to address cultural safety and humility and anti-Indigenous racism. So this kind of speaks to some of that came out of the In Plain Sight report on Indigenous healthcare workers. So actually having developed the appropriate processes so that healthcare workers can also have a place to go when they need to report acts of that they found were culturally unsafe or of discrimination or racism of any kind. And that and that these reporting practices are implemented. And again, that there's a clear accountability framework addressed so that once things are reported, that there is adequate resources and procedures around how that person is going to be supported, as well as how the incident is going to be addressed. It's also important to look at strategies for the recruitment and retention of Indigenous healthcare workers to, again, ensuring that we are getting representation at all levels. To build a culture of quality and safety. And so this comes back to highlighting the recommendations around developing a speak up culture, and that there are multiple different ways and mechanisms to respond to feedback in safety incidences, that there's confidentiality that's ensured, and ability to clearly communicate the response to First Nations, Métis, and Inuit clients, that feedback is incorporated to improve services for those individuals. And there's QI processes developed to respond to feedback and reports. These incidents are taken seriously and prioritized. Training is offered in response, and positive feedback is also communicated. Ways to address harm incorporates cultural safety best practices and spoke to the nature of creating a position like an ombudsperson. And so with this, it's also important to note the idea that speak up culture, creating an environment where we can give and receive feedback around from our colleagues and others about the care that we are providing, so that we can continue to grow and improve our cultural awareness and humility. Design and deliver culturally safe services. And so I will say when they're talking about human capacity and building that culture of quality and safety, particularly around QI, it's important to note when they're referencing data that they also reference the need for transparency and publicizing this data. So that again, there is that accountability, and that when tough reports are shared or that sort of thing, that it is still shared so that we have a clear understanding of where we are. So again, that we can work together to improve the situation. So design and deliver culturally safe services. And so for this, the foundational principles was that that these services are built with a strength-based and holistic lens on health and well-being, and not based on the deficit model that has often been taught in healthcare settings. To validate that indigeneity is our strength. It is what has kept us well since time immemorial, even when we had suffered grief and loss and trauma prior to contact. And due to colonialism and the disruptions in our connections to our community, land, and culture, we have developed healthcare disparities. And so it is colonialism and racism and culturally unsafe care that has led to the current health disparities that we see, including a widening disparity gap between Indigenous and non-Indigenous people. And so it's important that we acknowledge that our indigeneity is our strength. And therefore, if we're trying to create culturally safe spaces, we need to do that with that acknowledgement, incorporating our holistic ways of knowing and being, and uplifting our teachings and people in this space. Trauma-informed best practices, as well as incorporation of traditional wellness practitioners, as well as elders into healthcare delivery and design is vital. And the last one was to collect evidence and conduct research and evaluation. So foundational principles that this needs to be done to follow OCAP principles when collecting data on Indigenous peoples, including effective governing policies, procedures, research that is done in partnership, adheres to Tri-Council policy, including the joint statement in Chapter 9, needs to be respectful and respond to priorities of community, that there's reciprocal accountability, including adequate compensation, the use of data for organizational QI, use of Indigenous methodologies, co-developed metrics, data informs and improves their service delivery. So this speaks to the fact that it's not just collecting the data, but actually having mechanisms and resources to respond to what is found to actually improve the health of the health and well-being of Indigenous people. Organization reports regularly on how they are doing, and that helps to inform those reciprocal accountabilities, and that it evaluates their partnership regularly. So it's a big document. Even just reading the slide probably seems like a lot, and I'm happy to share the summary. And so from this, from the standards, I went through and tried to distill the pieces around cultural safe services, which a lot came out of Chapter 7 of the standard, but it was really layered throughout. And so again, coming back to the need to create culturally safe and welcoming spaces for Indigenous people, it's that tone that is set when people walk in. And so this could and can include art from the lovely Lisa Boyven that's displayed here. It could include books and magazines, although I think after COVID we do this less, but that is ensuring that we have things available that represent diversity within Canada. Also, sometimes when there's spaces being redesigned, looking at things like equity walkthroughs and other ways to ensure that there's a consideration of systemically oppressed and underserved groups have a say in what would help them feel safer in those spaces. Plan and implement regular cultural safety and anti-Indigenous training, education, and relationship building opportunities in new practice. So again, coming back to that, this is a journey. It's not a tick box exercise. I still attend trainings on this. I listen to many of my colleagues and I learn so much from them. And I'm always evolving in my cultural awareness and humility journey as well. Incorporate Indigenous elders, knowledge keepers, and healers into care delivery whenever possible. Develop a regular reflective practice and a speak up culture in your clinic or team. And so oftentimes when we level set by just stating that, hey, I want to receive feedback. If you see something that you think may be resulting from some subconscious biases, or you feel like you want to give me feedback on how an encounter went, I am open to that. And I would also want to be able to provide you with that feedback. Having times and opportunities to do this can be particularly powerful in a group when we think of things like valent groups and that sort of thing. Because the regular self-reflective practice is really important and is foundational. However, sometimes we don't know what we don't know, and when we kind of have really deep blind spots, and when we have trusting relationships that enable us to hear tough feedback, that can be very, very helpful. Develop in the speak up culture, it's important to note that I'll speak to it in a little bit, so I'll come back to that. Develop and or share the processes for staff and our clients to report culturally unsafe incidents, racism, and harassment. So again, you've seen it was a recommendation in plain sight, and it came clearly through an HSO standard that we need to have effective processes to be able to have people report when something did not go well. And from my perspective, I think a holistic view is to say we need to be able to collect feedback in a safe way so that we understand the impact of our words and actions on our colleagues as well as the people we serve. To work with Indigenous leads to co-develop QI metrics to improve your own processes and practice and for reporting purposes. So again, comes back to that shared accountability, so that, you know, that it starts with truth. So even when things are tough, that we need to promote a culture that we're sharing what's tough, and we're committed to the process of making it better. Clinical practice guidelines. So it's important to introduce yourself and explain your role, acknowledge and address power imbalances. Just like my introduction in the beginning and the land acknowledgement, that helps to locate and center me. The call to incorporate Indigenous methodologies and knowledge throughout this work also came through. And one of those ways is to locate ourselves in the work. In Indigenous ways of knowing and being, there's no way you can separate the observer from what you're observing. And so it's important that people know and understand the lens that I'm sharing information from, because in our belief system, it fundamentally impacts what we're sharing. And by locating ourselves, we create that shared understanding of where we're coming from. And in clinical setting, acknowledging and addressing power imbalances and looking for ways to create more equality is really important, or systems and processes that allow people to feel safe to speak up if needed, despite the power imbalances. Explaining the services provided and when to access, building relationships and spending time with clients and to listen to their stories, prepare Indigenous people for exams, explain them, obtain informed consent, and repeat asking for that consent, especially if it's a long exam or if multiple areas need to be examined. And so just speaking to these two, in my work with Carrie County as well as FNHA, one of the things that I see and hear a lot from when we collect feedback is that people really value the time they get to spend with providers. And it can be really hard when we're in a situation where we, in healthcare, where we may be short-staffed or are facing a lot of different pressures. But finding those opportunities and times that we can connect, where we can spend a little bit more time listening rather than doing, it repeatedly comes up as very valuable. And because it helps, without time, it's hard to build relationships. And especially if you're involved in episodic care, being able to spend more time helps to build that relationship for that interaction. And due to the colonialism and ongoing discrimination of Indigenous people, many Indigenous people are accessing healthcare system already with hijacked nervous systems. They're already in a fight, flight, or freeze response. And so by taking a little bit of time, being able to build that relationship, it can help them to regulate, to be able to come and be more present, which helps them to be able to hear and distill what you're trying to share and communicate with them regarding their health and well-being. And again, coming back to those trauma-informed best practices. Regarding consent, one of, and I'll speak specifically for Indigenous women here, one of the major impacts of colonialism was on erasure of Indigenous women, so being minimized, pushed to the back, as well as the lack of body autonomy. So we were very sexualized, and many of the impacts of colonialism was to say that we actually do not have control over what happens to our bodies, and especially the harms in healthcare related to the forced and coerced sterilization of Indigenous women and other experimentation. This consent piece is a way that we can give people their power back to say, you have control over what happens to your body. I may be a doctor and I may be suggesting that we do this exam, but you can say no. You can ask me to pause. You can say, I want to come back tomorrow. And that is always your right. And it comes to, just like we talk about connection to the land, reconnecting to our body is vitally important for that connection to happen. And when we give people the opportunity to practice and own body sovereignty, it's incredibly empowering. And when I do women's health and PAPS, I spend a lot of time explaining women's rights to them. And oftentimes it can be very emotional for them to say, like, nothing, like anything I do to your body without your permission is wrong and is harassment, and you can say no. And so I just, it's a thing that's very important to me. And so just wanted to highlight it. Welcome and encourage support people to be involved in their care if they wish. So oftentimes, especially in the community, I may see whole families. They may ask for elders or other people to be present, maybe other members of the care team that they have a special relationship with. And I always encourage it, obviously, with their express consent, detailing which parts they may want them in and what not. But it helps them feel safe in situations where they often do not. Use inclusive and accessible language, express concern, and use a respectful tone. And it's important to respect cultural beliefs and practices. All right. And so I feel like I'm getting close to the end. And so I can quickly go through the standard, or we can move into questions and answers. The standards, really the things that I wanted to highlight with them is that standards are reflect the minimum standard of professional behavior. So meaning these are not lofty goals. These are foundational principles that every provider should do. And what I like about cross-secting in plain sight with the standards, with the college guidelines, is the fact that it kind of shows and highlights the overlap around some of the key principles. And so, again, coming back to the idea of self-reflective practice, it starts with me. We all have biases. It's not our fault. It comes from the fact that we are in a racist and sexist society. And we have a responsibility, especially as healthcare providers, to not let the bias impact patient care. Building knowledge through education. That's important not just to acknowledge anti-Indigenous racism, but to actually be anti-racist. And this again comes back to developing that speak up culture and being an active participant and not bystander. Creating safe healthcare experiences. And so again, incorporating Indigenous ways of knowing and being into practice, looking at your practice space, that sort of thing. Person-led and relational care. And so again, pointing to like how we develop those relationships, address a legacy of mistrust, and then strengths-based and trauma-informed best practices. So again, acknowledging the historic and widespread traumas that Indigenous people face because of colonialism, creating a legacy of intergenerational trauma. Oh, I don't know how to go back. I don't think I need to though. Yeah. And again, recognizing the intersectionality so that Indigenous women, girls, two-spirit, non-binary, and other gender individuals are disproportionately impacted, and that there's an intersection between racism and misogyny that heightens the impacts in health disparities that we see for those individuals. And so this is just a definition of self-reflective practice. And with Speak Up culture, I just wanted to highlight the fact that I often hear, like, how do I call out racism in my colleagues? And I often come back to saying, I think first is, how do I develop the shame resilience skills I need to have people be able to call out racism in me? Because it's important that feedback always involves two. And although we don't necessarily, we can give feedback and not need to own people's responses. And it's important that we also know that shame and blame are not effective social justice tools. And so looking at ways that we can hold people accountable in respectful ways is helpful. And so part of how we can do that is by cultivating the skills for us to receive difficult feedback. And then working on all of those good tips and tricks we know about delivering hard feedback in a good and respectful way. I love this medicine wheel because it centers culture and it comes back to indigeneity is our strength. And I think we're at the end. So I'll stop sharing and see if there's questions, comments.
Oh, thank you so much, Terri. That was fantastic. Marcelo Bravo and I are going to hop back up now and moderate any questions that come in. So if anybody in the audience has online or in the room has questions, I'm going to put the microphone so that Terri can hear you.
Hi, can you hear me, Terri?
Yes.
Dr. Aldred? My name is Amy, and I teach nursing students out in Tsimshian territory in the Northwest. Thank you very much for your presentation. I have a question about a slide it was the first slide that had the beautiful art on it. And all of the things you mentioned, you were summarizing changes that can be made. And it seemed to me that there was a lot of roles for Indigenous people to play. And I wonder if you could speak to how to avoid placing an undue burden on Indigenous people to play all of those roles and all of those steps.
Yeah, that's a great question. And so certainly representation can be challenging. And I would say in my own personal experience that especially as these reports and recommendations were being released, that there was somewhat of a knee-jerk reaction to say like, okay, we need to put somebody from FNHA or an Indigenous person on every committee and, be part of every meeting and that sort of thing. And in particular for our elders and knowledge keepers, some of our community members highlighted that they became less available to help support them in their communities. And so just to acknowledge that there are sometimes ripple effects and that there's just not enough of us to sit on all of these tables. Even within FNHA, which, has a growing organization, we're still much smaller than our regional health authorities. And so there may be, there may be 50 tables for every one major group or a topic. And there's just no way that we can support every single table. And so looking at being strategic and working with them to look at, where would representation be the most helpful? What are ways that we can actually bring our stuff to Indigenous tables? FNHA has its own, governance table, engagement processes and feedback, regular connection with nations. And so rather than always making Indigenous people come into your space, how do you reach out and go into their spaces? And then also ways that we say like, engage, like it's kind of like reduce, reuse, recycle, and everybody thinks about recycle and don't always think about the first two. Engagement is important throughout the healthcare system. It's also important that we support and give resources to Indigenous people, communities, and organizations so that they can lead and implement things for themselves. And so that it's not this endless cycle of engagement where sometimes it's hard to know where that goes or how it informs or impacts the end products. Whereas if there's opportunities for Indigenous people to at least co-lead or lead, then that work is kind of built in throughout. And so, so I think there's multiple different levels to look at this, and I think it's nuanced and needs to be kind of thoughtfully assessed. And people like Indigenous health departments as well as FNHA are great resources to help to develop some of that pre-work around what is respectful engagement, what's a good process.
Thank you. More questions. There you go.
Hi, my name is Rachel. I'm an advisor for Indigenous patient experience for Indigenous health. Part of my job is calling out people, or we also say calling in to learn and adjust how we practice. But can you give any examples of conversations you might have had, like how you approach that? Having difficult conversations, especially when people feel they are giving culturally safe care, but you obviously see and feel that they're not. Yeah, how do you exactly handle that?
Yeah, so I love the principles and practices around looking at calling in versus calling out. And oftentimes during educational sessions, I talk about how, like, you know, people show up to educational events, conferences, because they're looking for additional information that can that they will likely critically examine and incorporate or digest in some sort of way. So essentially that I'm here to call people in because I believe that's why people have showed up. And that calling out is important, especially when explicit harm is happening. And obviously that can be more tricky. The biggest thing is that we don't. I think, yeah, and so I think testing the waters around it is often helpful. And so, for example, you know, I'm somebody who identifies as cisgendered, able-bodied, and if there was something that I did that maybe you know that would impact somebody who is maybe non-binary or trans, or who have different abilities. Like I would think I'd be a person that I would just want to know. I'd be just so grateful for that feedback. And so if somebody approached me to say that they want to give me that feedback, and my response is, oh yes, please, I want to hear that feedback, and I'm so committed to doing better next time. Coming at it with you're a terrible human and made me feel horrible is probably increases shame and defensiveness for somebody who's already eager to learn. And so whereas if you're approaching somebody and they are resistant to feedback, they don't seem open for whatever reason, oftentimes there could be a number of things that are going on. So I mentioned shame. And so we have made racism, sexism, a lot of these isms into a moral issue. So we equate being racist with being a bad person, that there's something inherently wrong with me if I'm racist, rather than an approach like a medical error approach where we say, actually, we're all racist. It's all of us. I'm not pointing fingers at you, I'm pointing fingers at me too. And it's about how can we do better together to reduce impacts. But because it still felt like a moral issue, most people experience shame, especially with specific examples on how they may be exhibiting bias in whatever way. And so sometimes it could be fine talking about it as an umbrella, but getting specific feedback can be really hard. And we all have go-to ways that we respond to shame that are protective for us. Like we either push it away, so we deny. I was like, no, I'm not racist, which it sounds like is something that you mentioned is people's resistance. It could be fighting, be like, no, that's not racist. No, this is, and like justification, you know, like this is why I do this way. You know, there's lots going on. I was working really hard. The person had a great outcome, you know, from my perspective, like, so there's fight, there's freeze. Like some people may just totally shut down, stop hearing. And so, yeah, and so acknowledging, if we come at things from a trauma-informed perspective, to say, if they're in shame, like if they're in a hijacked state, they're not going to be able to listen anyway. And because they're in their amygdala and their prefrontal cortex is shut down. And so, coming from a relational aspect and thinking about things in terms of, I'm totally blanking on the word right now, but essentially restorative justice aspects is to say like, hey, like I care about you. And the only reason why I want to give you this feedback is because I know you really want to do a good job. And receiving this feedback is really tough, and it doesn't seem like now is a good time. Maybe we can come back at a different time to discuss this feedback. And that's just like an interpersonal. When things are in a complaints perspective, like obviously things are already tabled, and there's going to be resistance, you know, because people are essentially scared. And so, yeah, so, but I think that again, like we can, like as people delivering feedback, we can own 50%, right? We can do everything right and people still may not accept it or respond well, no matter what we do. And so that's where those reciprocal accountabilities come in, because I think, you know, I think obviously trying trauma-informed and relational ways first is important. And if somebody is still not open, still not adapting or changing, and people are legitimately being put in harm's way, then as a system, there's an onus to say that, you know, we need to protect those that are oppressed and underserved, and your actions and words are not acceptable, and there's resistance to actually doing better.
Just to recognize, there's a comment in the chat by River. This was an incredible presentation. I'm deep in reflection of my own practices as a white settler, both in frontline work and background work. I'm privileged to have done a lot of learning work and know that this learning and thoughtful action is a daily practice. Thank you.
Okay. No, it's all good. That was wonderful, Terri. Thank you so much for this time with us today. It's more of a comment than a question, I think, although it's not fully formulated, so it might turn into a question, I have to admit. It really resonated with me, your you know, the comment that, you know, a strengths-based approach sees indigeneity as a strength that keeps people well, and that it's colonialism that's causing harm and illness, not indigeneity. And I think it just kind of really resonated. As researchers, we have a responsibility when we're framing our research questions from the very beginning to make sure that we're really attending to that and not sort of inadvertently framing the way we ask our questions that, you know, is going to bias us or end up in a result that really puts indigeneity under the lens and the microscope rather than putting colonialism under the microscope. And so I think it just really resonated for me what you said. And I think there's things we can work on as a community to put colonialism under the microscope. Thanks so much for your talk. Did you want to add to that?
Good morning, Hadi, Terri, Margot Parks here. I really appreciated your conclusion and humility in acknowledging the depth of commitment to reflective practice on the matters that we just heard about, from also about strength-based practice and things like Balint groups. As a medical student, I went to Balint groups, and it really changed how I thought about reflective practice as an ongoing, relentless commitment to your own learning. And so I just wanted to really underscore that message for everybody here, and to really thank you for leaning into that commitment that we all have to keep learning, given the face of the racist institutions and contexts in which we all work, that this is not something that we do and gets done, but that we're committed to for the long haul. So thank you so much for the depth of wisdom you shared today.
Thank you, Margot, and it's so nice to hear your voice. I can't see you, but it's so nice that you're here.
Were there any other questions? Okay, well, on that note, I'd like to give Terri another round of applause. Thank you so much for.
If I could just end then with a quote, because I love quotes, by Brené Brown. To build courage in teams and organizations, we have to cultivate a culture in which brave work, tough conversations, and whole hearts are the expectation, and armor is not necessary or rewarded. And coming back to, we can only offer those what we offer ourselves. So be kind to yourself in this work, cultivate self-compassion and empathy. Yeah, I hope the rest of your conference goes well. And just holding my hands up to all of you in this space. Thank